Another turning point, a fork stuck in the road. Time grabs you by the wrist, direct you where to go. Don't make the best of this task alone, that's why. It's not a question, but I'll have to learn in time. It's something unpredictable, but in the end it's right. I hope you had the time of your life. So take a photograph, take some present for mine. Hang it on a shelf and do it up anytime. Take you some memories, you time.
Welcome, everyone. Good afternoon, graduates, families, and distinguished guests. Welcome to the Summer 2021 Orange County Masters of Nursing pinning and program presentation. We have multiple graduates here, obviously, who have worked with their instructors over this past term on a evidence-based project that they're going to present to us in the first half of the program. So what we're going to do is we're going to allow the students to come up in their groups, present the program, and then we will take a break afterwards. But welcome and thank you for your patience in waiting for us. And if I could have the first group come up and introduce themselves, that would be great. Oh, Molly.
Good afternoon, everybody. My name is Kashika Singh, and my team members are Molly Cachadorian, Dara Delgado, Jocelyn Garcia, Kristen Mirhan, and Alyssa Rivera. We are here today to discuss our evidence-based quality improvement project, the Fall Limiting Intervention Plan. Next slide, please. Our poster includes the statement of the problem, the background, the microsystem assessment, the microsystem assessment results, the nursing implications, the fall limiting intervention plan, and the nursing relevance. Our team determined the following statement of the problem. Between July 2020 and May 2021, in a large metropolitan teaching hospital, there were 16 falls on a 28-bed telemetry unit. The goal of the unit and the organization is a total of 0 falls. Next slide, please. A fall is defined as any occurrence when the patient unintentionally rests on the ground or other lower surfaces. It results in negative outcomes like skin lacerations requiring closure, casting, traction, strains, sprains, neurological consults, and blood administration. This leads to avoidable physical and psychological pain for the patient. In the United States, it was estimated to have about 700,000 to 1 million individuals fall during their hospital stay. Between 30 to 35% of these patients face an injury related to the fall. Each of these injuries can add up to 6.3 days to their length of stay, adding about $14,056 per injury. The U.S. spends about $50 billion per year on medical expenses related to falls. Medicare spends $28.9 billion, or 6% of their expenses, while Medicaid spends $8.7 billion, or 8% of their expenses, to cover the cost of falls per year that were not fatal. Falls that were fatal or led to deaths cost an approximate of $754 million in medical expenses. This is a significant economic burden, and it's vital to decrease the number of falls, both fatal and non-fatal. Next slide, please. To cover the cost of falls per year that were not fatal. Falls that were fatal or led to death.
To gain a better understanding of fall contributions on the unit, our team created a microsystem assessment. The microsystem assessment consisted of 10 survey items with a mixture of Likert scale, multiple choice, and free response questions. Participants were instructed to answer the questions truthfully, to the best of their knowledge, and they were informed that the answers would remain anonymous. The survey questions were available to nursing staff for a total of 21 days, and a total of 30 participants completed the survey. 25 participants identified as registered nurses, and the remaining 5 participants identified as nursing assistants. Our survey focused on the Bedside Mobility Assessment Tool, or BMAT, which is the current hospital-wide assessment tool used to evaluate a patient's ability to ambulate. Based on strong evidence found in our literature review and our root cause analysis, our team decided to place BMAT at the center of our intervention. The BMAT rates a patient's mobility level on a scale from 1 to 4, with BMAT 1 patients requiring maximum assistance and BMAT 4 patients requiring minimal to no assistance. Each BMAT score is associated with varying assistive devices and equipment appropriate to the patient's ability to ambulate. Next slide, please.
Questions 1 through 3 helped us gain a baseline understanding of the patterns, perceptions, and processes of nursing staff and how they might pertain to current fall prevention practices. As you may notice, there is some variation throughout the questions. For question 1 and 2, you will notice that a majority of participants expressed that they had a decent knowledge of BMAT scores for patients assigned to other RNs. However, approximately 23 to 33% felt that they didn't know the BMAT scores of other nurses' patients, or they only sometimes or rarely checked the score before assisting those patients. In addition, the data suggests inconsistencies in the frequency of mobility assessments during bedside report, which you see demonstrated in question 3. Survey responses show that 43.3% of staff reported always communicating the patient's mobility status during bedside report. However, this left a remainder of 56.7% that failed to discuss the patient's mobility status during handoff every time. Next slide, please.
So based on the pie charts from the previous slide, free response from nursing staff, and fall incident reports, we identified communication deficits as one of our prominent themes. This is denoted on the fishbone diagram here in purple. Communication deficits can occur between nursing staff as well as between nursing staff and patients. Poor communication between nursing staff can occur when there's a failure to discuss topics such as a patient's fall prevention plan, their mobility status, level of assistance, need for assistive devices, and baseline mobility assessment. Between the nurse and the patient, there can be discrepancies between the patient urgency and the time till nurse attendance. Staff also express their concerns over equipment shortcomings. That is the unavailability, limited quantity, faultiness, and fulfillment delays of fall prevention equipment. Some of the reoccurring responses about equipment deficits are denoted on the fishbone diagram and are highlighted in red here. Most notably, several nursing staff also reported that bed alarms were not available or functioning, and sometimes the alarm volume could be inaudible from the nursing station. Next slide, please.
The third theme focuses on the BMAT knowledge gap and is based on answers to clinical application questions that ask nurses to assign BMAT scores to hypothetical patient scenarios. 20% to 30% of nursing staff actually assigned the incorrect BMAT score in these scenarios, which prompted this team to further investigate the hospital's BMAT pocket card, which you can see on the left here on the slide. As you can see, this card uses 4 color-coded horizontal boxes to organize BMAT scores. It lists the most severe mobility deficits at the top of the card and proceeds downward to the least restrictive mobility level. The team discovered that nurses would often confuse the top and bottom bars and the 2 bars in the middle of the card when prompted with these questions. For example, a survey item asked, a patient who requires complete assistance with moving in bed or ambulating would be given what BMAT score? The correct answer to this question is BMAT 4. However, 30% of survey respondents actually answered that question with BMAT 4. The correct answer is BMAT 1, but 30% answered it with BMAT 4. Similarly, for answers that were BMAT 2 and BMAT 3, nurses showed that they were confusing those answers. At least a portion of nurses were confusing those answers. This led us to believe that a portion of the staff could be confused by this current pocket card and could use an improved version that had another visual cue that could improve their BMAT understanding and improve nursing knowledge on this helpful tool. Next slide, please.
We hypothesized that with the absence of visual cues on the BMAT cards, nursing staff were misinterpreting the scoring system. Thank you. To mitigate this issue, the team designed updated BMAT cards, which we call Fall Limiting Intervention Plan cards, also known as FLIP. Flip cards include the same colors and scores used in the current system, but contain additional icons to prompt stronger visual associations to mobility status. The team chose icons according to the unit's most commonly used mobility devices and easily recognizable visual icons relating to the color of the card. For example, the BMAT 1 card is displayed in the color red and contains a stop sign, while the BMAT 2 card is in the color orange and contains an orange safety cone. Next slide, please. The BMAT 3 card is the color yellow and contains a caution sign, while the BMAT 4 card is displayed in the color green and contains a green light. Flip cards are designed to be interchangeable through a simple flip around a metal ring that can be hung on a wall hook and displayed in an easy-to-see bedside location. Next slide, please.
The current project is broken up into 8 phases and will take place over a total of 12 months. We were able to complete phases 1, 2, and 3 this semester. During phase 1, the MSN-CNL student team obtained baseline data for patient falls on the telemetry unit, conducted a thorough literature review of fall prevention strategies, and created questions to be used in the microsystem assessment via an online survey. Phase 2 involved building relationships with key stakeholders. The team had to obtain buy-in from nurses and nursing assistants who would be implementing the flip cards onto the unit. We were also fortunate enough to be given the opportunity to meet with unit leadership to discuss the problem and present our proposed solution, flip cards. During phase 3, microsystem assessment data was collected and the findings were analyzed. Future teams will continue at phase 4. Phase 4 will consist of the preparation of educational materials, training, and staff resources. The MSN-CNL student team will educate staff through videos and interactive scenarios demonstrating proper use of flip card intervention. In phase 5, the team will implement the intervention on the telemetry unit over a 6-month period. Phase 6 will focus on the evaluation of fall data throughout the implementation period in order to determine if there has been a decline in the number of patient falls. Staff knowledge will be evaluated using a post-implementation survey containing BMAT application questions similar to the microsystem assessment survey questions. Random audits will be performed by the team to ensure that flip cards are being used throughout care delivery and as intended. Next, phase 7 will consist of final data evaluation, dissemination of the intervention results, gathering staff feedback, and discussion over future directions and sustainability of the project. Finally, phase 8 will place an emphasis on staff appreciation for participation in the quality improvement project in order to express gratitude and boost staff morale. Next slide, please.
Barriers and obstacles must be identified and addressed to ensure that the intervention is not only successful, but sustainable. One obstacle that future teams may face is the lack of incentive for nursing staff to complete educational training. Staff education serves to address the gap in BMAT knowledge. Another barrier stems from inadequate nursing assistant knowledge regarding BMAT. The nursing assistant scope of practice does not include assessment, meaning that nursing assistants are not required to understand BMAT scores and their relation to each patient. FLIP alleviates this issue by re-educating RNs on BMAT, and it also introduces the concept of BMAT to nursing assistants who may not previously be familiar with the tool. Nursing assistants are also unable to view patients' BMAT scores in the electronic health record. Because of this, the FLIP intervention ensures that all disciplinary team members that enter the patient's room are aware of the patient's BMAT score and ambulation needs by placing the BMAT card in a visible location above each patient's bed. The accessibility of the card also encourages other healthcare professionals, such as physical and occupational therapists, to update FLIP to display the current BMAT score. Next slide, please.
So, although our team did not have the opportunity to implement flip cards on the unit, our team focused on completion of phases 1 through 3. After meeting with the unit manager, it was determined that future MSN-CNL students can pick up the project at phase 4 to begin preparation of the flip intervention. The unit managers and leadership team eventually hope to see our intervention implemented, not only on their telemetry unit, but across the entire organization. This includes all of the medical surgical units, as well as the higher acuity units, such as step-down and intensive care units. Next slide, please.
Ultimately, we hope that FLIP will contribute to the organization's ultimate goal of 0 patient falls. FLIP shows promise in decreasing the financial penalties associated with inpatient falls by providing nursing staff with a user-friendly and cost-effective tool. My fellow nurses, remember, FLIP, don't trip. That concludes our presentation. Thank you so much for your attendance this afternoon, and we'd like to invite up Group 2. Remember, flip, don't trip. That concludes our presentation. Thank you so much for your attendance this afternoon, and we'd like to invite up Group 2.
Alrighty, hi everybody, good afternoon. My name is Elizabeth Leon. This is David. We have Kalechi, Alicia, Melissa, Bianca, and Melody. And today we're going to talk about our project, which is ensuring uninterrupted continuum of care.
So, standardized communication between the interdisciplinary team is important for patient-centered care, patient safety, and patient and staff satisfaction. We first conducted a 5 Ps microsystem assessment. The purpose of this project was to conduct a quality improvement project to implement at a community-based, freestanding pediatric hospital here in California to study the effects of the creation of a standardized handoff tool for floor registered nurses to provide to preoperative registered nurses in the preparation of pediatric clients for surgery. Next is professionals. The professionals of the interdisciplinary team in charge of taking care of patients at this current microsystem include physicians, physician assistants, nurse practitioners, registered nurses, certified nurse assistants, and the list goes on. Next is patient population. The patient population of this hospital consists entirely of pediatric patients aged 0 through 18 years of age, with demographics primarily being Caucasian, Hispanic, Latino, and Asian. The processes at this microsystem include inadequate handoff and a lack of client preparation when clients are transferred to the preoperative unit. There is currently no existing standardized handoff when the preoperative registered nurses receives report from the RN from an inpatient unit. These errors that have occurred include a patient wearing an inadequate gown, the IV not being patent, or maybe the patient, him or herself, not having an empty bladder prior to surgery. Patterns include delays in care, unnecessary repetition of the same actions, the presence of errors, and overall disorganization of the transfer of a client to the preoperative unit. So, there is a need for a tool meant to provide guidance for inpatient RNs to properly prepare clients for the preoperative unit, and that would also provide guidance to a standardized verbal handoff when transferring to the preoperative RNs. Next, please. So, the problem statement is as follows. Preoperative registered nurses have expressed concerns over communication issues that the handoff reports from inpatient registered nurses were either missing information or contained irrelevant information, and that the pediatric clients were insufficiently or inconsistently prepared for the preoperative unit. Ultimately, clients not prepared for surgery and incomplete handoff reports affected safety events, surgical throughput, and client and staff satisfaction. Next, please. Either missing information or contain irrelevant information, and that the pediatric finds were insufficiently or inconsistently prepared for the pre-op.
Oh, thank you. In order for us to standardize transfer of care communication among preoperative nurses, we used the PICO system, which is Population Intervention Comparison and Outcomes, as a module for us to outline our clinical research question. Our population is the pediatric operative unit. For intervention, we seek to create a tool for client preparation and standardization handoff that will be user-friendly for preoperative and post-op nurses. And for comparison, we're comparing having no tool nor having standardized handoff. And also our outcome will be the overall effect of surgical throughput for staff satisfaction and safety events. So our PICO question is, in a pediatric unit, how does having a tool for client preparation and standardized handoff between inpatient and preoperative nurses compares to not having any standardized handoff tools? For us to stay on track and successfully implement our project intervention, we formulated 3 main goals to support our project question. Our goal number 1 is to create a standardized cover sheet checklist that will include an opportunity for nurses to ask questions, clarify any information, and confirm reports with an adaptive usage across the continuum of care for the first 3 months of implementing our intervention. Our goal number 2 is to reduce the amount of delays in the preoperative unit for clients by 25% at the end of the first 3 months. And lastly, we hope to increase the average satisfaction score for the preoperative nurses by at least 1 point by the end of the first 3 months of implementing our intervention. Melody will be talking about our root cause analysis for this project. Next slide, please.
So our group conducted a root cause analysis to determine the need for the standardization of patient handoffs from inpatient nurses to preoperative nurses. We determined that 6 areas are affected by this lack of standardization: patients, professionals, processes, environment, equipment, and patterns. Without a standardized handoff tool, inpatient nurses don't necessarily have a clear outline of what information needs to be included in the patient reports to pre-op nurses. This can lead to a failure in transfer of proper information, which can also lead to the failure to make proper preparations before transportation. Furthermore, inpatient nurses are often busy with 4 to 5 patients that they have to take care of. This time constraint can lead to multiple issues, such as interruptions during telephone reports, which would lead to incomplete handoffs. They might have to prepare patients in a hurry, which could lead to a lack of proper equipment, and all of this will lead to delays in patient preparation and transportation, which then increases the workload for pre-op nurses. They have to spend extra time gathering the missing information as well as the missing supplies. All of this leads to a delay in patient care, which then decreases patient satisfaction. Next slide, please.
So for our intervention, we designed a standardized handoff cover sheet that the nurses will use with every patient scheduled for a surgical procedure. The first section of the handoff sheet is the preparation for handoff sheet, which is a quick checklist for nurses to use to ensure that the patient is ready for transfer. The prep sheet includes information such as checking whether the patient's ID is in place, the consent is in the correct language and is labeled and in the chart, the patient's gown is on with no clothing underneath, the jewelry has been all removed, the patient's last void is properly documented in the chart, and the patient's COVID test, date, and result is documented. The second portion of the cover sheet is based on a popular 5P standardized handoff tool, which is a tool that nurses use to guide them through the verbal handoff process. Our specific tool consists of 4 subheadings: patient, problem, plan of care, and pending. The patient subheading covers the personal identification, date of birth, allergies, medical history, and any precautions, such as seizure precautions or restraint use. The problem subheading covers information such as preoperative diagnosis, surgical procedure, correct site and side of the procedure, complications such as abnormal vital signs, and the presence of any any equipment such as tracheostomies. The plan of care subheading covers information such as IV lines, drains, dressings, and any incision sites. Additionally, it has the oxygen and ventilator settings, and lastly, the plan of care after the actual procedure is done. The pending subheading, which is our final subheading, includes pending labs and diagnostic tests, such as x-rays, EKGs, and echocardiograms. Now, to measure the effectiveness of the actual tool, of the surgical cover sheet, the team used data collected from nurse satisfaction surveys. These surveys will be conducted 3 times. The first one is during our pre-implementation phase. The survey is especially important because it provides our baseline data, and it also allowed the nursing staff to provide detailed information about the current handoff process and any communication gaps they have observed during transfers. The next 2 surveys will be conducted midterm at 3 months and the final survey at 6 months. Now here you can see we designed a Gantt chart, which is a visual representation of our project's timeline, and we divided the project into 3 different phases. Phase 1 has a duration of 5 weeks and 3 tasks. The first task is to conduct a survey group meeting and interview. The second will be to meet with the Continuum of Care Committee at the hospital, via Zoom in our case. Lastly is conduct the initial survey with the nursing staff, which provided our baseline data. Phase 2 is the implementation period, which has a duration of 6 months or 27 weeks, just over 6 months. The tasks include design the in-service education module, deploy the education module, implement a reminder system just to remind the nurses that this project is ongoing, and to implement the actual handoff tool. Lastly is phase 3, which is our post-implementation phase period. This has a duration of roughly 8 weeks. The tasks include conducting the midterm survey at 3 months and our post-implementation survey at 6 months. If the handoff tool fails to meet the desired outcome of reducing nurse dissatisfaction, the PDSA cycle will be restarted next semester with a new group of students, allowing the team to adjust and re-implement an updated cover sheet until the desired outcomes are met. Next slide, please.
So as David mentioned, in the pre-implementation period, satisfaction surveys were distributed to nurses on the surgical floor and the recovery center. 60 registered nurses responded, 38 from the surgical floor and 24 from the recovery center. So currently, when asked how satisfied they are with the current handoff between inpatient and preoperative nurses, 53.3 responded with somewhat satisfied and 23.3 with very satisfied. And when asked in regards to how satisfied they are with the preparation of inpatients for surgery, 29.2% were somewhat satisfied and 20.8% were very satisfied. So if our surgical handoff tool is effective, we expect that at the end of the first 3 months of the implementation, there will be an increase in average and preparation satisfaction scores by at least 1 point. So this should translate into an increase in percentage of somewhat satisfied and very satisfied responses. And we also expect a decrease in the delays in the preoperative unit. Next slide, please.
We created a budget for the project, and it accounts for paid 30-minute training for 30 nursing staff and 1 CNL that will be leading the teaching sessions. The paid training will approximately be $48 per hour. There are an estimated 50 surgical cases per day, and each handoff packet will cost 2 papers to print. The total estimated cost per year for the program implementation is roughly $2,200. Interrupted handoffs and unprepared patients lead to increased rate of adverse events and OR delays. Through our research, we found that OR delays cost an estimated $20 to $30 per minute. We are estimating that there is a 5-minute delay per hour, and our goal is to decrease those delays by 25% with our program. Estimating that adverse events cost roughly $1 million per year, we hope to decrease the rate of adverse events by promoting concise handoffs and clear expectations of how to prepare patients. In total, it is estimated that we will save $48,000 with the implementation of the program. Next slide, please.
So the CNL, The role of the CNL in our project serves as an educator. So they are there to teach and coach the healthcare members how to perform and how to perform the standardized handoff. So they're there to be available to answer any questions about the implementation, and they're also there to supervise the correct usage of the standardized handoff. Secondly, the CNL also serves as an outcome manager. They gather data from the surveys and they interpret what areas need improvement and determine if the implementation of the standardized cover sheet improved delays, allowed for an improved continuum of care. I mean, if it doesn't help out, then we need something else to make it better, right? And Benders et al. Study found that if CNLs improved patient outcomes by creating a microsystem, because they were able to provide a stable and consistent practices where nurses are able to perform better and at their maximum capacity. Thirdly, CNLs also serve as risk anticipators. So the CNLs perform a root cause analysis to determine why handoffs to the pre-op nurses are resulting in delays and in the continuum of care of patients. So that's exactly what we did here today. As CNLs, we were able to look, why are these delays happening and how can we improve them and make them better so we can keep the system going. Lastly, CNLs serve as system analysts. So they're there to evaluate the microsystem and recognize that the lack of a standardized handoff causes delays in care and an overuse of resources. Ernst et al. Study found that improvements in nursing handoff can result in better nurse-to-nurse relationships because there will be less miscommunication happening between them. They result in better patient rapport. If patients are spending more time in the handoff and gathering supplies and talking to their patients, then they can't build that rapport with them. So hopefully this standardized handoff will allow for nurses and patients to have a better relationship. And lastly, they're also there to enhance the nursing quality of care. The less time that nurses are spent running around trying to gather last-minute information, the more time that they can spend to really, truly educate their patient and make sure that they have a successful surgery. Next slide, please.
So now we're going to talk about the discussion portion of the project. For the evaluation, in order to evaluate how effective the implementation of the standardized checklist, we will be conducting post-implementation surveys. There will be a 3-month and a 6-month survey that will be sent to the nursing staff. The data will then be collected and assessed, and the survey results will show their effectiveness and success in the unit. The main recommendation for safer handoff reporting to standardized checklist that will be specific to the pediatric, preoperative, nursing staff on the unit, as well as to meet the patient needs. We also recommend for future CNL students to do continuous research and to monitor the implementation of the standardized checklist to make further adjustments and necessary changes to improve the outcomes. In conclusion, with the helpful success of this intervention conducted in the microsystem, this quality improvement project can be implemented hospital-wide to other units to also improve nursing staff communication, patient safety, and increased handoff satisfaction. Next slide. This is our visual of our poster. And this concludes our presentation. And now we invite Group 3 to come up. Thank you.
All right, guys, halfway there. 2 more. Good afternoon, everyone. Our group would like to share our quality improvement project that we've been working on. It's based on fall prevention, more specifically on eliminating preventable falls that occur on the telemetry unit. Our group members are myself, Rachel, Kim, John, Nicole, Angel, and Michelle. Next slide, please. So this includes the poster that we created, and we're going to go ahead and break it down for you on the next few slides. Next slide. Falls and injuries from falls are the most prevalent patient safety problem in healthcare facilities. Hundreds of thousands of falls occur in U.S. hospitals annually. 30 to 50% of these falls result in injuries that prolong length of stay by an average of 6.3 days. These falls cost around $14,000 per fall injury. Furthermore, these falls most frequently occur in patient rooms and bathrooms. A quality improvement project focusing on fall prevention was created and executed to eliminate falls within the telemetry unit in a large suburban hospital. This unit had 31 falls in over 90 days, with 61% of these falls related to toileting. This is greater than the hospital's target of 0 and greater than the Agency for Healthcare Research and Quality's estimated average. Therefore, developing a fall prevention quality improvement project is essential to reducing high fall rates, preventing serious injuries, and decreasing healthcare costs. Next slide. A specific aim was created using a P-coat technique, which ensures that the formula needed in order to conduct research can be completed. P-coat consists of population, intervention, control, outcomes, and time. Our population is based on fall risk patients within the telemetry unit. Our intervention, which we're going to further elaborate on, is purposeful rounding every 2 hours, use of call, don't fall signs, and post-fall emails. For our control, we use fall statistics from 10 weeks prior to our intervention with the main goal of having an outcome that will eliminate falls within the telemetry unit with a timeline of 10 weeks. Next slide. And now I will pass it on to Angel to go over the methodology.
Good afternoon. I will be going over the methods portion, which consists of a microsystem analysis, a SWOT analysis, and lastly, the Cotter's change theory. In the next slide, we will be going over the microsystem analysis. We first conducted a microsystem analysis. Our team used the 5 Ps, which became a useful baseline for gaining deeper knowledge and awareness of the current state and begin to target opportunities for a fall prevention improvement. So let's get to know our microsystem. The purpose of this unit is to provide telemetry level of care. Telemetry level of care is used to characterize deteriorating cardiac conditions, arrhythmias, and improve cardiac management. This unit cares for a broad population of patients who are being treated with cardiac medication emphasis. There are many professionals on this unit, and I will highlight a few. There are registered nurses, certified nurse assistants, telemetry monitor technicians, physical medicine, respiratory therapists, and physicians. And the nurse-to-patient ratio is 4:1. We also analyze the current fall prevention process in this microsystem, which is the pre-intervention, and it's as follows. We have a fall risk assessment using the Morse Fall Risk Scale, physical medicine and documentation, yellow fall risk armbands, yellow non-slip socks, yellow blankets, yellow door signs, and lastly, hourly rounding, which consists of the 5 Ps, which are pain, potty, possessions, pathways, and pumps. The current fall patterns within this microsystem are as follows. There were 61% of falls related to toileting. 88 were unwitnessed, 12% were witnessed, and 45% occurred during night shift. 55% occurred during day shift, and 34% with safety measures documented. Over a period of 90 days, there were 31 falls. In the next slide, there will be a SWOT analysis that we performed. The SWOT analysis that we performed analyzed the strengths, weaknesses, opportunities, and threats, or also known as SWOT, of our fall prevention intervention. The most important strength to consider in this intervention is the high return on investment. Fostering any change requires unit staff buy-in, which may be a weakness if not enough is gained. An additional weakness is when implementing the intervention may include a lack of patient compliance to staff and safety recommendations. The opportunities that will result from the implementation of the fall prevention interventions include a high return on investment, which will lead to increased available funds, and HCAP survey improvements. A lack of interprofessional collaboration, buy-in, along with time commitment feasibility can be factors that may threaten the success of our fall prevention intervention. In the next slide, we'll have our Gantt chart. The Carter's change theory was utilized in our fall prevention project. Carter's is an 8-step process for leading change, and the duration of our task was 130 days. And a big portion of our time was devoted to phase 6, which was generate, and phase 7, which was sustain and capitalize wins. During these 2 phases, the unit staff will be working as usual, but with the implementation tools in place. Feedback will be obtained by the fall committee, and change will be monitored using electronic health records, randomized check-ins with patients assessing if they themselves were educated on the call don't fall sign, and lastly, assessing if and when falls occur were post-fall emails completed. The second phase is used in order to create short-term wins for the benefit of long-term change. Incentives such as first pick and scheduling, taking off a holiday, or taking off a weekend will be offered to the staff members who are actively executing and implementing this process. This process will continue for 10 weeks. So now, John will be sharing with you all the interventions we implemented.
Alrighty, can you guys hear me? Okay, awesome. So our project aims to eliminate falls on the telemetry floor through the implementation of not 1, but 3 new evidence-based interventions to workflow design to improve safety measures while decreasing risk for patient falls. So our first implementation will be the use of purposeful rounding every 2 hours to replace the hospital's non-mandatory rounding every hour during day shift and every 2 hours during night shift. Purposeful rounding will encompass the use of a toileting script and environmental checks. The second implementation will be the utilization of a call don't fall signage to educate patients on fall precautions and the importance of calling the nurse when getting up. Self-reflective post-fall emails in which the nurse will send out an email to the staff member within the unit after a fall has occurred will be our third implementation. So next slide, please. So here's our toileting script. This is our first intervention, so it will be a 2-hour purposeful rounding, as previously stated, and here we'll be assessing the 5 Ps. So we have pain, potty, position, possession, pump, and equipment. And also this will include toileting opportunities and scripted prompts for the nurses. So this will include, let me help you to the bathroom now. I don't want you to have to wait for the call light later to go. I'm here now and have time right now. So let's go to the bathroom. It'll also include explanation to the patient during toileting that you'll be watching their shoulder or foot, and as soon as you see them move, you'll be coming in to help them in order to keep them safe. Next slide. So this is our second intervention. This will be a laminated card that you see here, and it involves the use of additional educational tool that will be reviewed with patients at the beginning of every shift. This educational tool will come in the form of a visual card that is laminated with place for patient name, date, BMAT score, fall risk factors, assistive devices required, toileting schedule, and visual representation of what kind of assists are needed when moving the patient and ambulating the patient. Nurses will be able to erase and update the laminated card every shift with updates in progress from physical therapy. The motivation behind this change in practice is to provide daily education to patients about the importance of alerting staff members when needing to get up or ambulate while simultaneously reinforcing to the nurse what level of care the patient requires. Next slide, please. And our third and final implementation aims to produce a sense of accountability within nursing peers. This objective looks to create a safe reporting environment without repercussions, creating a culture of system failure rather than person failure. The focus will be to create a communication unit team-based approach through holding accountability with a minimal blaming culture. This will be accomplished through incorporating additional implementation of a post-fall email beyond the current incidents reporting system that is already in place. This post-fall email will require an email from the nurse responsible for the patient explaining what happened, as well as at least 2 ways in which the situation could have been avoided or protocol can be improved for next time. Requiring these emails will motivate nurses to be more vigilant of falls, but also give perspective to working nurses and the realization that falls can occur to any nurse no matter what level of experience. The goal is to not only help other nurses learn from mistakes, but assist nurses in remaining vigilant for all fall risk patients. And now Michelle will talk about CNL relevance.
So the clinical nurse leader role, or the CNL, encompasses many areas, including but not limited to systems analyst, risk anticipator, outcomes manager, educator, and client advocate. Overall, CNLs use evidence-based practice to reduce healthcare costs and improve patient outcomes. Our project conducted a microsystems assessment to determine the needs of the telemetry unit. We created a multi-component intervention based on our findings and evidence-based practice. The success of our project greatly impacts nursing practice, as it shows the effectiveness of using multiple interventions to prevent patient falls. Patients are complex beings, and there are often multiple factors that contribute to a fall. The interventions we developed were address the needs of the client and were patient-centered. As such, future quality improvement projects should take this into consideration. Simply using the Morse Falls risk scale is not enough. While the interventions we developed can be improved upon through future PDSA cycles, our project provides a strong blueprint that can be built upon and adapted for later use in future microsystems. Overall, our project demonstrates the CNL's ability to effect long-lasting positive change within a microsystem. While the interventions we developed can be improved upon, prevent injuries caused by falls, and consequently decrease the length of a hospital stay. Next, Rachel will talk about how we evaluated our project.
In terms of evaluation, the following data will be collected by the CNL to evaluate staff compliance with the project interventions. 1, the number of times staff members documented purposeful rounding during each shift. 2, the number of post-fall staff emails sent. And 3, the number of successful charge nurse check-ins with patients, evidenced by patient correctly verbalizing the fall education and staff updating the call don't fall signage. Next, please. Our expected results, based on literature review, is that the total number of falls was projected to decrease from 61% during toileting to 3%, or a total of 1 fall in the telemetry unit, with a goal of 0 falls in the post-intervention period. In addition, the intervention is expected to be successful in increasing staff and patients' awareness regarding fall risks and fall prevention. Next, I'm going to pass it on to Nicole.
Next slide, please. The estimated startup and operating cost of the fall prevention intervention amounts to $751. If falls decrease to 0, this would generate a savings of $309,125. After calculating the return on investment, the result is 41,162%. This value indicates that returns greatly exceed the costs of implementing the fall prevention intervention. In conclusion, patient falls result in unnecessary costs and poor patient outcomes. This project implemented multi-component fall prevention interventions to decrease hospital length of stay, prevent patient falls, and eliminate fall injuries. It will remain sustainable using Cotter's change management model to achieve staff buy-in and use incentives to encourage team member participation. Unit champions will continue to lead implementation after the project has ended. PDSA cycles will be used to revise the project as changes and problems arise. Furthermore, the interventions can be adapted for use in other similar microsystems. In conclusion, this project has the potential to create a long-lasting impact on the telemetry unit at a large suburban hospital. Next, Kim will discuss the recommended next steps of our project.
For our recommended next step, we suggest incorporating the Plan, Do, Study, Act cycle, also known as the PDSA cycle, in addition to policy change. So the PDSA cycle will be implemented if the interventions do not meet our anticipated goal. So for example, a study conducted by Dykes and Associates in 2019 concluded that patient falls were due to gaps in communications and when plan of care were not individualized to each patient. Therefore, as part of our quality improvement intervention, we created a laminated poster to use as a patient education tools to incorporate family members and patients as active participants in their plan of care to prevent falls. The poster will be hung across from the bed of the patient in full view of them at all times. The goal is for the nurse to use these education tools to update the patient on any assessment that may increase or decrease the patient risk for fall. The nurse would then initial and date the poster to indicate that education was given that shift. However, what do we do if staff adherence to the poster is not what we expect it to be? Then we will start in the plan phase of the PDSA cycle. In this step, the committee will decide on improvement goals, determine what are the barriers that prevent nurses from adhering to the poster, and what data are necessary to show improvements. In the do phase, the plan is carried out, data is gathered, and documentation of the problem will occur. In the study phase, the committee will analyze the data to compare to the predictions made in the plan phase to examine what lessons were learned during the implementation. Finally, in the act phase, the committee will decide whether to adopt the change and then progress to the standardized do, study, act cycle, also known as the SDSA cycle, or to implement further changes, or to just abandon the interventions completely. In regards to policy change, the implementations of this process will last approximately 10 weeks. After the 10 weeks, committee members will obtain feedback, analyze pre and post implementation data to strengthen and weakness, to observe for strengths and weaknesses of the interventions. The data will then be used to encourage staff acceptance and support for hospital-wide implementation. The final policy will include the needs and views of all parties involved, and we will ensure that there is a long-term sustainability. Thank you everyone for listening to Group 3 presentation. Next up, Group 4 will be presenting the quality improvement interventions.
Hi everyone, can you hear me? Yeah? How are you feeling? Good? Okay, how'd you think about the last 3 groups? Weren't they great? Okay, if you can all stand up with me and give a round of applause for the last 3 groups, that would be great. More energy, come on. There we go. Okay, well, my name, for those of you who don't know me, is Eden Flores. We have Joanna Vialta, Kimberly Pimentel, Casey Marcelo, Nicole Kim, and Camille Ruiz. And together, we chose to focus our CNL project on standardizing the discharge education for post-cardiothoracic surgery patients. Thank you for our presentation. Just kidding, I wish it was that easy. Next slide, Joe. So, the discharge education process for patients recovering from cardiothoracic surgery, also known as CT surgery for short, is often meticulous and lengthy. As you can see from this slide over here, it's much more complex than what it initially seems. In order for patients to fully understand the information that's being provided to them, a learning needs assessment must be performed prior to providing the discharge education. This assessment allows for education to be specifically tailored to fit each patient's learning needs. Educational topics range from lifestyle modifications to wound management and return demonstrations on skills such as medication administrations and the use of home health equipment. To assess the effectiveness of the teaching, nurses should utilize the teach-back method. Now, you may be thinking in your heads, what in the world is a teach-back method? Well, just as the name implies, it requires the patient to teach back the information that was originally provided by nurses. Further education will be provided to the patient to address any gaps in knowledge following the patient's teach back. Next slide, please. Unfortunately, there's several barriers that impede the discharge education process. When paired with nurses who are caring for multiple highly acute patients, inappropriate nurse-to-patient ratios, and constantly changing staff, it's very easy to overlook critical components of the discharge education that's supposed to be presented to the patient. Additionally, fragmentation in communication has been found to increase risks of deficient patient knowledge of the information that has been presented, along with an increased risk of hospital readmissions. In 2019, Gao and his colleagues found that this increase in fragmentation in communication and discharge education and planning led to omissions of pertinent information regarding the patient's discharge and ultimately avoidable errors. This ended up resulting in an increased rate of hospital readmissions, something that's very costly for both the patient and the hospital. Now, another barrier to effective discharge education is a lack of standardized nursing knowledge. An initiative was implemented at a magnet-designated acute care hospital. In this study, Matina et al. Provided educational opportunities for nurses on heart failure and its 30-day impact on readmission rates. Now, the results were astonishing. This study concluded that statistically, there was a significant increase in the percentage of patients receiving discharge education from unit nurses and an increase in the mean number of days patients received this education. This meant that patients were actually provided the opportunity to effectively learn how to transition from the hospital to the home while preventing post-surgery related hospital readmissions. Sorry. One moment, please. Okay, so based on the current literature on evidence-based discharge education practices, this study identified standardization as the intervention that best addresses gaps in effective discharge education and education documentation. Understanding that quality improvement initiatives are continuous and repetitive processes, this project utilized the Plan, Do, Study, Act framework to improve the quality of discharge education for CT surgery patients. The efficacy of this intervention will be evaluated using self-reported pre-intervention and post-intervention surveys aimed at quantifying nurse perception scores as they relate to providing efficient discharge education to CT surgery patients. Next slide, Joe. This project was implemented on a cardiovascular surgery unit at a large teaching hospital within the Orange County metropolitan area. The specific aim of this project is to increase the percentage of nurses who agree that discharge education is standardized from a baseline of 36% to 60% by the end of this month. Now, following a year of program implementation, including continuous quality improvements to patient education, nursing education, and education documentation, the global aim of this project is to reduce readmission rates of CT surgery patients into the cardiovascular surgery unit by 20%. Next, we'll have Casey and Joanna go over the methods we implemented to make this project possible.
So to reiterate what Eden said, more specifically, the project was implemented in a 16-bed cardiovascular surgery unit that serves the healthcare needs of its surrounding communities in Orange County, California. The hospital is driven by its mission statement to discover, teach, heal. The patients on the unit range from ages 18 to 90 and are 26% from Hispanic descent and 15% from Asian descent. Of the diverse ethnicities and cultures on the unit, about half of the patients are non-English speaking, with Spanish and Vietnamese being the most spoken languages. The healthcare team on the unit consists of physicians, nurses, physical, occupational, speech, respiratory therapists, monitor technicians, and complementary health practitioners. The unit was created in April 2020 and recruited nurses from different specialties and units within the organization, and also recruited travel nurses during the coronavirus pandemic. Currently, there are no standardized discharge processes and documentation practices for CT surgery patients. Topics presented during discharge are inconsistent and vary significantly among the nurses. Moreover, patient teaching is presented in a presentation format, which limits patient understanding and patient engagement. Over the past year, the hospital performed 317 cardiac surgeries, and of these, CT surgery accounted for 38 unplanned 30-day readmissions. Moreover, during the past year, the hospital had a low performance score and ranked 94th out of 101 academic medical centers. Thus, these patterns on the units and the unit's high readmission rates revealed gaps in the quality of patient teaching and documentation.
Next slide, please. So we conducted interviews for the unit culture assessment with the unit leadership advisory board. We found that nurses did not express a high confidence level on appropriate discharge education teaching material provided to patients. When looking at the electronic medical record, the EMR, nursing documentation revealed inconsistent patient discharge education, a measure indicating the need for an intervention to standardize the discharge teaching process. As a result, a root cause analysis was performed to aid in identifying and categorizing the cause to the lack of standardization in the discharge process and documentation practice. As you can see, some of the issues that contributed to the problem were nurses coming from different units and specialties, inconsistency in topics presented in patient teaching, as well as lack of training or active learning techniques. Next slide, please. To gather more information, a unit needs survey was created for the post-cardiothoracic surgery nurses. The survey was conducted with a quick response QR code that was posted around the unit to allow nurses to submit their answers easily and anonymously. A total of 40 nurses were given time to participate and complete the survey and were asked to agree or disagree on 5 questions. For the purpose of this project, we focused on 2 main questions. 1, the current discharge education process is standardized, and 5, availability of resources for discharge education on the unit. 36% said that they thought the current discharge education process was standardized, while 64% did not. When asked whether they thought resources were readily available on the unit, responses were evenly divided at 50%. So based on these survey results, we identified nurse-patient education standardization as the main need for this unit. Our plan to standardize involves implementing education through the use of handouts that would also serve as a tool for patient discharge. The intervention aims to improve workflow, manage variation in patient education, and enhance nurses' knowledge.
Next slide, please. So implementation of EPIC education titles and discharge handouts will not only improve patient outcomes, but will also provide more resources for nurses and allow healthcare providers to view patient progress through the continuum of care. However, as the unit is still new, success of the project may be thwarted by low support by the unit and low sustainability. To prevent these issues, new and ongoing roles can be created specific to the project, such as an IT specialist, a project champion, and a clinical supporter. So despite the weaknesses and limitations of the project, it has more strengths and weaknesses. It has a low startup cost, it has a short development period, and it has opportunities to widen and expand to other languages and provide culturally relevant health. This will all allow the project to deliver and maintain its intended benefits in the unit.
Next slide, please.
Standardizing the discharge patient education process on the cardiothoracic surgery unit proved to be a multi-intervention implementation process, including patient education, nursing education, and the documentation process. However, only the first part of the project was implemented. To begin the standardizing process, a cardiac surgery booklet was created to use for nurses as a guide for CT surgery patient education. The booklet was accessible to nurses online. To standardize patient teaching materials, the key topics from the booklet were used to create user-friendly handouts. 8 handouts were created. 1, chest precaution. 2, incentive spirometry. 3, wound management. 4, potential challenges at home. 5, daily responsibilities. 6, cardiac rehabilitation. 7, frequently asked questions, and 8, when to call the doctor. We have included an example handout on the poster board, and you can see all the handouts playing here on the PowerPoint. The handouts were written at a 3rd grade reading level and included illustrations with written instructions to ensure patient comprehension and facilitate learning. These handouts can be used to make discharge packets and supplement patient teaching. Considering that most of the patients on the unit are non-English speaking patients and have limited health literacy, it was important to design the handouts according to their learning needs and present only pertinent information to prevent information overload. Keeping this in mind, it's essential to create handouts in different languages in the future. On the next slide, Cam will go over the results.
Now, in the allocated time that our team was given to work together on this project, we were able to identify various interventions, all of which were appropriate to be implemented on the cardiac step-down unit. We did narrow down our quality improvement project to one intervention, as KP had just mentioned, the cardiac handouts regarding discharge education, and this intervention was indeed approved by the unit management team and staff. As our quality improvement project evolved, we did experience ongoing complexity, and the transformation of which most appropriate intervention to choose was evident throughout the duration of our project. As with any project, we experienced some challenges along the way. We had 2 primary challenges that we experienced throughout the 3 months of working together. Number 1 was the issue of time constraints. We only had 3 months to plan our interventions, implement the interventions, study the results of the interventions, and then act according to the study that we found. In addition, we experienced some challenges related to the current COVID pandemic. So for one, because we were not able to be regularly in the hospital, we were unable to meet with the unit staff and discuss the progress that we had of our project throughout the 3 months. In addition, we didn't have the opportunity to gather relevant patient information personally. So we were not able to each go through patient charts and do some chart auditing to look at readmission rates, as well as look at if the patient education was documented by the nurses, and if patient education was documented, exactly what education was documented into their EMR system. In spite of these challenges, our team was able still to successfully gather information, and we did combat some of these challenges by meeting with the unit staff via Zoom. Despite the challenges that we faced, we did present a plan for evaluation and identified key components of continuing the development of this quality improvement project. In alignment with our specific aim, we hope to increase the percentage of nurses who agreed that discharge education is in fact standardized from our initial baseline of 36% to an anticipated 60% by the end of August 2021. Now, most specifically, we were hoping that the increase in percentage of these nurses related to the 2 factors that Joanna had mentioned. Number 1 being we hope that the increase in the nurses' ability to identify available resources for patient education was readily available on the unit, as well as we hope to see an increase in nursing confidence that the discharge process is indeed standardized on their unit. The next steps that will occur to follow implementing the cardiac handouts that we provided includes some collaboration with members of perhaps other disciplines, including members of the informatics team, ability to development patient education teaching methods, such as the patient teach-back method that Eden had alluded to. And finally, there's opportunity to develop nursing education workshops and simulations. In the next slide, Nick is going to go ahead and talk about a little bit deeper what our next steps are.
Thank you, Cam. So this first iteration of this project focused on making discharge education materials readily available to the unit nurses, but simplifying extensive instructions and compiling the available knowledge into readable handouts is only the first step to standardizing patient teaching. In fact, this project is multifaceted and has the potential to be carried on by the unit as well as future nursing cohorts. During the 3-month implementation of our project, it was realized that standardization of the discharge education process will ultimately be achieved by impacting 3 components: patient education, nursing education, and education documentation. And it is our hope that future projects will continue this work. So in regards to standardizing patient education, going forward, the quality of the education should be measured using the teach-back method in accordance with evidence-based practice. The next steps would be to conduct an audit of the CT surgery patient population in order to understand systemic gaps in teaching so that learning needs can be addressed. The handouts produced during this project are a tool to be used by the nurses to provide standardized and clear instructions, but it is not a replacement for the education that nurses provide at the bedside. As for improving nursing education, future projects can work on establishing an education program geared toward new and onboarding nurses. According to interviews with the leadership board, nursing education is best facilitated with simulations and practice scenarios. The desired outcome of such a project would be to standardize nursing knowledge and improve confidence, which would translate to improved patient education at the bedside. And finally, documentation of patient education can be made more streamlined so that every nurse involved in the care of an individual patient can coordinate so that every education topic is taught. Currently, the EMR used at this hospital does not distinguish between relevant education topics, simply labeling the entirety of preoperative, intraoperative, postoperative, and discharge education under the single heading, patient education. In collaboration with IT services, a future project can create more specific EPIC education titles corresponding to each relevant topic for CT surgery patients. Not only would this serve as a standardized checklist in order to ensure that patient education is comprehensive, it would facilitate clear documentation so that nurses can provide necessary education without being repetitive or omitting critical information. To conclude, we are confident that our project will serve to aid nurses in their responsibility to provide clear, effective, and standardized patient teaching in order to improve patient outcomes and ultimately readmission rates. Thank you. Oh, on the next slide's our poster. Thank you.
Thank you.
On the next slide's our poster. Thank you.
All right, thank you, ladies and gentlemen. You did a fantastic job. I'd like to give them all another hand. Thank you. Okay, sorry, now I can breathe. I just wanted to let you know that we're going to take a 10-minute break, just to give everybody a chance to stretch a little bit. Those that will be pinning your graduate, when you come back in the room, please sit on the right side, because this way then you'll be able to come up at the same time as your graduate so you can pin them, okay? So thank you very much, and we'll see you back in about 10 minutes. Okay, yeah, no problem. You guys did a very good job. Hello? I would get better turned on. Yeah, so what I'm going to do, can you hear me? Yeah.
Another turning point, a fork stuck in the road. Time grabs you by the wrist, direct you where to go. Don't make the best of this task alone, that's why. It's not a question, but a lesson learned in time. It's something unpredictable, but in the end it's right. I hope you had the time of your Don't take the photograph, just don't press it for mine. Hanging on a shelf and good on anytime. Take these memories,
Excuse me, if I could please have everybody take their seats and the graduates please go outside to line up for the second part of the program. Thank you. Excuse me, if I could please have everybody take their seats and the graduates please go outside to line up for the second part of the program. Thank you.
and welcome to the second part of our program, the pinning ceremony. Pinning is a symbolic ceremony that welcomes newly graduated nurses into the nursing profession. It is a solemn occasion. It marks the end of a rigorous educational program and the beginning of a life of service to those in our community that are in need. It is time-honored tradition that new graduates look forward to with excitement and pride, and they should. They've done a phenomenal job. If you research the origins of the pinning ceremony, it is common to see that the pinning ceremony has roots in the 12th century when knights who aided the sick and infirm were given a Maltese cross to wear. On a lot of our pins, we have Maltese crosses. Additionally, you will find that Florence Nightingale, the mother of modern nursing, was awarded the Red Cross of St. George for her tireless work with the sick and infirmed during the wars. Florence Nightingale then started the practice of awarding a badge with a Maltese cross to all nurses when they graduated from her nursing program. By the early 1900s, the pinning ceremony was a tradition the nursing graduates look forward to in the United States and England. On your here, I forgot what it's called, sorry. You'll find on the program, thank you, you'll find on the second page is much more information on the pinning ceremony. What we'll do first is we're going to start out with our student speaker. So Yasmin Sadakiani, if you could please come to the stage.
I didn't tell my parents I'm doing this, so they're shocked. Hello and welcome to the pinning ceremony for the summer class of 2021 Cohort 8. Les Brown once said, "The greatest obstacle you'll have to overcome is your mind. If you can overcome that, you can overcome anything." We are all here today because we overcame our minds. We struggled, to put it lightly, before and throughout nursing school. Every single one of us came into this program with different degrees and backgrounds in order to pursue nursing, a degree that was chosen by the Guinness Book of World Records as the toughest degree among all college degrees. To take that even further, we chose a program that is just that, but the accelerated version of it. Were we nuts? With that said, it is obvious that nursing school was not easy. There were many tears shared with our classmates, family members, significant others, pets, plants, Professor Bueno. We spent many nights on campus studying, sometimes sleeping, throughout the entire night until the sun went up. Some of us even ended up getting locked out of the rooms and having to call security to help us back in. We did all this so we can ensure we knew as much as we could before a big exam. Clearly, it worked because we are here today. We just also may have lost our minds along the process. We now know the F word in nursing very, very well. Don't worry, everyone, I'm referring to the word flexibility. We have seen many changes throughout our program and have been continuously challenged because of them. I mean, we finished nursing school in the middle of a pandemic. Faculty members were challenged to provide hands-on training and direct patient interaction for their students completely online. Because our faculty fought for us to continue the program, we were blessed with the opportunity to find ways to complete our clinical hours. We are grateful for our professors who advocated for us and did not stop searching until they found a solution. So yes, we had to spend long days answering phone calls for LADPH. And yes, we had to learn to transition to online classes, but we made it. We battled, we persevered. Now, I would like to mention that nursing school did not always feel like an impending doom was following us. We had some great moments that we will cherish forever. I apologize to everyone that is not in our program because this next part will not make sense to you. But let us not forget, writing a 15 to 20 page care plan only to be ripped apart and having to do another one the following week. Waiting in the hallway, absolutely terrified before a skills sign-off. putting on a stethoscope to listen to breath sounds but not being able to hear anything. Or putting on a stethoscope to listen to breath sounds, finally hearing that breath sound, but not being able to identify what breath sound it was. Let us not forget Professor Ramon's drawings on the board during our health assessment class that would leave us even more confused than before, or his lovely handwriting that we could just never seem to make out, or Professor Vieira Martinez's sassiness that always seemed to keep us all fully alert and on our toes during class. Or how about the moment before simulation where you're scared, but you think, I finally have a plan going in. Yet as soon as you step inside, you forget everything you wanted to do, and you can't find anything in that room. Let us not forget being in med-surg class and trying to find a way to blend in on Zoom so Dr. O'Malley doesn't call on you to answer. Or that feeling of relief when you answer a question and hear Dr. O'Malley's famous, "sounds good to me" response. And I don't know about you guys, but I've taken many exams where I can just hear Dr. O'Malley's voice in my head during the exam. So thank you, I passed. And lastly, let us not forget the lifelong friends we have met in this program. Friends we will share the rest of our lives with and grow old with. We are here today because of the support of our family members and friends. We want to thank all of you because you all played a vital role in our journey. This journey was not easy, and we should be proud of our accomplishments. We went from taking blood pressures to starting IVs. We went from not understanding medical jargon to speaking in medical jargon and confusing our family members and friends. We now can't even walk down the street without assessing and diagnosing people that walk by. What we did was not easy, but we did it together. We overcame ourselves and that voice inside our head that told us we can't. We decided we can. I have a simple message for all of us. This message is not just for my cohort, but also for those of you sitting in the audience. Seek discomfort. Seek opportunities that challenge you. Seek opportunities that make you think there is no way I can accomplish this. Change your mindset and overcome yourself. Do not stop yourself from being great. You are your biggest obstacle. I will leave you with this quote spoken by Mr. Andy Bernard from The Office. I wish there was a way to know you were in the good old days before you actually left them. I am telling you now, these are your good old days, so take it all in and live. Thank you to my friends and future colleagues who you know as the summer class of 2021 Cohort 8. We did it, guys. We are nurses.
Thank you very much. That was wonderful. Now I would like to introduce Dr. Ryan O'Malley, the faculty speaker chosen by the cohort.
Thank you, guys. Usually brevity is not my strong suit, but I'll keep it short today. So first, it's really an honor to be the faculty speaker. I mean, definitely appreciate it. I also appreciate being able to teach you guys Med-Surg 1 and Med-Surg 2. I mean, I think those are definitely the most important classes, and those will give you the fundamentals that you need to do whatever you want to do. So thank you for that. It's kind of strange being back on campus. You know, I feel good being back on campus, kind of. You know, Zoom's convenient and all, but it's good to be back on campus. And, you know, the one good thing about campus, every time I go onto this campus, I see USF's slogan, change the world from here. Probably the most amazing slogan ever. I'm not sure, maybe Dr. Priyan knows who started that, but it's an amazing slogan. Why? Because as an RN and having your CNL competencies, you guys are in such a good position to change the world from wherever you're at, okay? To change the world, and especially with your CNL competencies, it really starts with advocacy, and I hope you guys really got a sense of advocating for your patients. You know, sometimes the patients that we take care of are the most vulnerable in our society, are the one who needs us most, and are the ones who are going to be, of course, in and out of the hospitals. So how do we advocate for people? Now, being in the U.S., I think we're all very, very, very blessed. I think very. Did I say very? Very blessed. Very blessed to be in the U.S. and everything. But, you know, our healthcare institution could use a little bit of help, just a little bit. And, you know, I think you guys are going to be in a good position to do that. And, you know, if we can start with advocacy, that would be really good. And I think the best way we can also advocate for our patients is really challenging the status quo. And for any of you guys that have never been in any of my classes, most of you guys probably, but you know, I always allow the students to challenge anything that I say, any test item, anything. Okay, Jocelyn, I think you contradicted me on Foley catheters once. I gave you a point on your test. In any event, nobody knows everything, and no institution is perfect. Okay? And I always want you guys to remember, you know, you're not right or wrong because Ryan O'Malley says you're right or wrong. You're not right or wrong because the textbook manufacturer says you're right or wrong. You're right or wrong because your facts and your logic make sense. So please, you know, please remember that when you're out there changing the world. And I really hope to see great things from you guys. And that's it.
Thank you, Dr. O'Malley. We're next going to proceed with the pinning ceremony where our graduates are going to be pinned. So if I can have the first row of graduates please line up and get prepared to be pinned. And then Ms. Allen, if you come up.
Alicia Alonso, pinner Mr. and Mrs. Alonso, Alicia's parents. Alicia Alonso, pinner Mr. and Mrs. Alonso, Alicia's parents. Rachel Sen, pinner Janice Feng, Rachel's friend. Rachel Sen, pinner Janice Feng, Rachel's friend. Kim Nung Chon, pinner Randy Wen, Kim's fiance. Kim Nung Chon, pinner Randy Wen, Kim's fiance. Dara Delgado, pinner Karina Garcia, Dara's friend. Eden Marie Flores, pinner Maricel, Eden's mom. Eden Marie Flores, pinner Maricel, Eden's mom. Jocelyn Garcia, pinner Victor Garcia, Jocelyn's dad. Jocelyn Garcia, pinner Victor Garcia. Molly Cachadorian, pinner Asia Mar, Molly's nursing professor. Molly Cachadorian, Nicole Jisoo Kim, Pinner Karen Kim, Nicole's mother. Nicole Jisoo Kim, Pinner Karen Bianca Lenartz, Pinners Patricia Lenartz, RN, and Andrew Reynosa. Patricia is Bianca's mother and inspiration, and Andrew is Bianca's boyfriend and support. And Andrew Reynosa. Patricia is Bianca's mother and inspiration, and Andrew is Bianca's boyfriend and support. Elizabeth Leon, Pinners David Leon and Angelica Leon, Elizabeth's parents. Elizabeth Leon, Pinners David Leon and Angelica Leon, Elizabeth's parents. Melissa Leong, Pinner Eric Leong, Melissa's brother. Casey Marcello, Pinner Eden Marcello, Casey's mom and #1 fan. Casey Marcello, Pinner Eden Marcello, Casey's mom and #1 fan. Jonathan Mang, Pinner Jerry Mang, Jonathan's father. Kristen Valerie Merhan, Pinners Violet Merhan and Mike Bueno. Violet Merhan is Kristen's mother, and Mike Bueno is Kristen's former professor and mentor. Pinners Violet Merhan and Mike Bueno. Violet Merhan is Kristen's mother, and Mike Bueno is Kristen's former professor and mentor. David Munoz, Pinner Precious, David's wife. Kelechi Agwuegbu, Pinners Evelyn Santa Maria and Ahana Ganika, Kelechi's friend and son. Kelechi Agwuegbu, Pinners Evelyn Santa Maria and Ahana Ganika, Kelechi's friend and son. Kimberly Pimentel, Pinner Mike Bueno, Kimberly's mentor. Elisa Rivera, Pinners Ada Solon and Luis Rivera, Alyssa's auntie and dad. Elisa Rivera, Pinners Ada Solon and Luis Rivera, auntie and dad. Nicole Robles, Pinners William Werner and Jessica Robles, Nicole's grandfather and sister. Nicole Robles, Pinners William Werner and Jessica Robles, Nicole's grandfather and sister. Camille Ann Ruiz, Pinner Christina, Camille's mother. Camille Ann Ruiz, Pinner Christina. Yasmin Sadagiani, Pinners Zore and Nader. Mom and dad to Jasmine. Yasmin Sadagiani, Pinners Zore and Nader. Angel Nicole Silva, Pinner Emma Silva, accompanied by Angel's brothers. Angel Nicole Silva.
That's great.
Pinner Emma Silva.
Oh no! There are more brothers.
Kashika Singh, Pinner Gabriela Aldaco, Kashika's mentor and nursing best friend. Kashika Singh, Pinner Gabriela Aldaco, Michelle Tran, Eric Danielson, Michelle's husband. Joanna Vialta, Pinner Ebelin Santa Maria, and Rosa Vialta, mentor and mother. Joanna Vialta, Pinner Ebelin Santa Maria, and Rosa Melody Yuan, Pinner Stephen Briles, Melody's boyfriend.
All right, thank you. Don't they look like an absolutely fantastic group of nurses? Yay! So, and now I would like to invite Dr. Knapp to please come up and do the Nurses Pledge. you. Don't they look like an absolutely fantastic group of nurses? Yay.
Congratulations. I know how hard you all have worked to get here. If we have any nurses in the audience, if they would join me in reciting the Nightingale Pledge. I solemnly pledge myself before God and in the presence of this assembly to faithfully practice my profession of nurses. I will do all in my power to make and maintain the highest standards and practices of this noble profession. I will hold in confidence all personal matters committed to the keeping of the practice of my calling. I will constantly endeavor to increase my knowledge and skills in nursing and use them wisely. I will collaborate with other professionals in the medical community and devote myself to the welfare of those placed in my care. I will seek to nurse those who are ill, wherever they may be, and whenever they are in need. I will endeavor to fulfill my rights and privileges as a good citizen and take my share of responsibility in promoting the health and well-being of the community. I will be an active in assisting others in safeguarding and promoting the health and happiness of all humankind. Congratulations.
Thank you. You guys can go ahead and down. Okay? Yeah, you can go ahead. Yes. Okay. Oh, they want a big group hug. Yes.
So ladies and gentlemen, family and friends, while we have them up here, can we get a little excited cheering for our graduates? And graduates, is there any excited hooping and hollering that you'd like to do? Yeah, do it! Thank you. Okay, lovely. No, I'll introduce myself. Okay. I have a speech to give. Graduates, is there any excited hooping and hollering? Yeah, wherever you want. Wherever you want. We are almost finished with the pinning ceremony, so graduates, if you don't mind taking your seats. I have the unenviable task of being the brief but memorable guest speaker that comes after the pinning. Thank you for that scheduling. Good afternoon. I'm Dr. Susan Prion. I'm the Associate Dean for Nursing. It is an absolute honor to be here with you this afternoon for this momentous event. We're here to celebrate an important milestone in the educational and professional journey of every nurse. A nursing pin is a type of badge. It's made of metal, such as gold or silver, and it's presented to a nurse when they successfully complete nursing school. Each school has their own unique pin design that symbolizes something about the history of nursing at that school and the values that the school holds dear. The nursing pin and the accompanying ceremony represent a meaningful and momentous transition for nursing students from student to healthcare professional. It symbolizes the completion of educational requirements and the preparation for service to others through nursing. It has become a recognized and respected symbol of accomplishment. Okay, so that's the formal description of what a nursing pin and the pinning ceremony is. How many nurses are here today? Raise your hand. Thank you for your service. How many of you not only have your nursing pin after how many years, but treasure it? Perhaps doing something like this with your nursing pins. Anybody? Yes? Why? Well, for me, I now have it like this because my pins went through the wash a few too many times, or got hooked on my isolation gown when I was going into a patient's room, or scraped my face when I took my scrubs off at the end of an exhausting shift in the ICU. The number of times that I have pricked my finger on what seems to be a little tiny pin when I was really too tired to fumble with that pin. In truth, this one, which is my undergraduate pin, it is probably not my first nursing pin. I think that at some point I had to order a new one, or maybe a second new one, because I kept losing it because I wore it every day to work. Even though I don't wear my pins every day now, I'm still really proud of my accomplishments and humbled by what this pin signifies. I now keep them in a frame in my office. It's actually a shadow box, and this is, I did not bring it because I came on a flight, and I was worried I was going to break it. But I show it to people when they come to my office because I'm really proud of it. I hope that each of you will treasure the pin that you have today. I hope that that you will wear it, and secretly I hope that you lose it sometime and have to get another one because you've treasured it so much that you've worn it every day as this important badge and symbol of your accomplishments. I want to end by telling you a story. My husband is a mathematician. Sometimes that's good, sometimes that's not so good. He's not a healthcare professional, and after many years of marriage, to be honest, he's probably a complete hypochondriac. So it's really fortunate that he's married to a registered nurse. On our very first date, this is embarrassing to say in public, but I will, to make a point. We were at a food court at a mall. We were not eating hot dogs on a stick, I assure you. But it became apparent that someone at a couple tables away was starting to choke. And they started to do all the things that indicate that they have an obstructed airway and are not breathing. And I can't remember what we were eating. I will swear it was not hot dog on a stick, but I remember calmly putting my implements, my napkin down, getting up and walking over and doing a Heimlich maneuver on the person. Made sure that they were okay, explained to their family that they probably should not eat hot dog on a stick, which is probably what they were choking on, and made sure they were okay and went back and sat down. And my then first date, not even boyfriend, eventually husband, said, how did you know what to do? And my question to him was, what do you think I do? I mean, like what is your perception of what nurses do? Fast forward many years later, we're at Chicago O'Hare Airport and we're waiting for an international flight. And it's Christmas time and the boarding area is really crowded and people are sitting all over the place. And a young woman has a grand mal seizure. bunch of physicians rush over, make sure she's okay, and in her post-ictal stage, y'all know what that is, thank you, Dr. O'Malley, she's been incontinent, she is unconscious, and she is a little crumpled heap on the floor, and everyone has left her because she's no longer seizing. So I sat down, went through her bag, figured out her name, started talking to her, tried to figure out what her medications were, tried to figure out who we could call as we were waiting for this flight. Did a lot of different things. And at the end of it, when our flight finally boarded and the paramedics had taken her away, the ground staff said, Priyan, party of two? Up I went and they said, hi, we only have 2 business class seats left. And we had a lot of people that responded initially, but we'd like to put the 2 of you in business class. And my husband, as I told him that, again said, how did you know what to do? And I said, what do you think I do? So every time that we fly, this is the honest truth, he always says to me at some point, does anybody look sick? Let's sit beside them. This is what we know how to do. This is who we are as nurses. I hope that your Jesuit education has given you a special sensitivity and concern for the vulnerable and the marginalized, and those suffering physically and emotionally and mentally. St. Ignatius of Loyola, who Dr. O'Malley I think might have come up with Change the World from Here. That's my bet. St. Ignatius of Loyola, founder of the Jesuits, reminds us that love ought to manifest itself in deeds rather than in words. This is who we are and this is what we do as nurses. We are so proud of you and, getting emotional here. We are so proud of who you are and who you will become. It's my honor to welcome you to our profession of nursing, the best job in the world. Warmest congratulations. Thank you all. Who's next? Oh, Slideshow. And thank you all very much. I believe we have a slideshow. Yes, Joe? And this is a slideshow put together by the students, so please enjoy. And thank you all very much. I believe we have a slideshow. Yes, Joe? And this is a slideshow put together by the students, so please enjoy.
Here's to the ones that we got. Cheers to the wish we're here, but you're not. 'Cause it just bring back all the memories of everything we've been through. Toast to the ones that are alive. Toast to the ones that we lost on the way. 'Cause it just bring back all the memories. And the memories bring back you. There's a time that I remember, and I did not know pain. When I believe in forever, everything stays the same. Now I don't feel like a stepper. Somebody step in. If I can't reach out to call you, I know I'm with my baby. Everybody hurts sometimes. Everybody hurts someday. Everything will be alright. Only the doctor say. Here's to the ones that we got. Cheers to the wish you were here, but you're not. 'Cause the dreams bring back all the memories of everything we've been through. Toast
Great slideshow, thank you. Next, I have the greatest pleasure in introducing one of your former professors. He's going to come and do the closing speech for you. So if I could please have Professor Michael Bueno come.
Hello, everyone. It's much more relaxing when I don't have to do all this plan. So, but good job, everyone. Hello, OC8. I don't think you can get rid of me that easy, right? But I'm kidding, but I'm very happy to be back in a place that still feels like home. I am also honored to be also asked to do the closing remarks because I was here when your journey began. But good job, everyone. And it brings me closure that I get to celebrate the end of it. Yet this is only the beginning. Think of your nursing career like the movie Jumanji. The one with The Rock, because you are all probably too young to know that Robin Williams was the one in the original one, right? So nursing school is like the part where you all pick your characters and learn more about yourself, your strengths and your weaknesses. But now that you are graduating, you enter the real game, where each level will get harder and harder. Instead of man-eating hippos, you have patients who are MPO trying to sneak in a snack. Instead of poisonous snakes, you have telemonitors that you can't tell if it's a VTAC or someone scratching their leads. And instead of getting lost in a jungle, you'll be getting lost in the clean supply room. And just like the movie, the only way to survive is to work as a team and use your individual strengths to your advantage. Lean on your support system, like they said before, to get you through the hard days and also share in the joys of the rewarding ones. And most importantly, be kind to yourself and know that you didn't get here by pure luck, but by resilience and perseverance. Not every nurse can say they survived nursing school and becoming a new grad during a pandemic. Especially during this time, you are needed more than ever. So the world welcomes you with open arms. And lastly, you've probably seen all the signs honoring our frontline workers, calling them heroes. But as far as I'm concerned, you don't need a pandemic to know that you all are heroes. You already became heroes when you decided to become a nurse. Congratulations, OC8, and good luck on the next level. Again, as part of USF Orange County, we'd like to thank you all for coming, and this concludes the pinning ceremony for OC8. Enjoy. Again, as part of USF Orange County, we'd like to thank you all for coming, and this concludes the pinning ceremony for OC8. Enjoy.
Hello? Hello? Cohort 8, can we please meet outside for a picture on the stairs right outside the door, please? Cohort 8, picture outside.